Welcome to the Seasoned Sonographer, the podcast where experience meets education in the world of OBGYN ultrasound. My name is Lynn Flam, and I'll be your host. I'm a registered diagnostic medical sonographer with over 32 years of experience, most of that time in OBGYN ultrasound. Through this podcast, I'm here to share insights, tips, and case studies to help you sharpen your skills and optimize your scans. Whether you're just starting out or you're a seasoned pro, this is the place to grow your knowledge and confidence. Let's dive into today's episode. Before we begin, I'd like to recognize the organizations that make this podcast possible. Sono helps healthcare providers strengthen the patient experience by securely delivering ultrasound images and videos directly from the ultrasound machine to the patient's mobile app, creating meaningful connections between patients, their families, and their care team. Southern Illinois Healthcare is committed to advancing exceptional patient care by supporting excellence in ultrasound education, innovation, and professional development throughout the region. Rochelle Health partners with healthcare facilities nationwide to connect them with highly qualified imaging professionals, helping ensure patients have access to expert diagnostic care when and where it's needed. And finally, Sono Techniques Academy, your comprehensive mobile and web-based OBGYN ultrasound education platform designed for sonographers, students, and healthcare providers. Thank you to Sono, Southern Illinois Healthcare, Rochelle Health, and Sono Techniques Academy for your continued support of ultrasound education and this podcast. Welcome to the Seasoned Sonographer podcast. I'm your host, Lynn Flam, and today we're discussing one of the most important examinations in obstetrical ultrasound, the first trimester ultrasound. Joining me is Dr. Keith Sanford, an OBGYN physician with extensive experience caring for pregnant patients. Together, we'll discuss the critical role first trimester ultrasound plays in pregnancy dating, confirmation of viability, reassurance to expectant parents, and early detection of abnormalities. We'll also discuss current recommendations from ACOG and AIUM, review the AIUM required first trimester images, and explore how sonographers serve as the first line of detection for many pregnancy complications. Dr. Sanford, welcome to the Seasoned Sonographer podcast.
Hey, thank you. Thank you. Good to be here.
Before we get started, would you tell our listeners a little bit about yourself, your training, your career in OBGYN, and your experience caring for patients?
I started OB. I graduated medical school from University of Mississippi Medical Center. I went up to Marshall University for residency, graduated in 2001. Have most of my career has been in rural health, smaller areas. Worked in Eastern Kentucky for a little while. Then we moved to Illinois, where I met you, and we, worked there at Shawnee and Carbondale, small towns. Then I became more of an OB hospitalist, just doing the OB emergency rooms. That was in through some of the organizations out there. And presently, I basically just work in a small community hospital as a laborist / clinician that does OB clinic. I only do OB in my practice, and I like OB, and so that's kind of what I carved my way out into that niche, and that's what I do. So
that's great. So from an OBGYN physician's perspective, why is first trimester ultrasound such an important part of prenatal care?
It's the joke's always been, if you could only get one OB ultrasound in a pregnancy, you want it less than 12 weeks. And like you kind of alluded to a while ago, once you establish, viability, that does, and the due date, I mean, basically everything from that point is then, is referenced back to that point. Every decision you make is based upon the gestational age. So, it makes a difference if you're dealing with a baby that's, 30 weeks versus 36 weeks. And, I'm old. I can remember when we used to have debates over LMPs and, when did we, when was the last menstrual period? What was the gestational age? And, first trimestral ultrasound which was not very common whenever I was a resident, has now become the gold standard. And we don't have those discussions anymore. I mean, we don't have the discussions, oh, she's really 34 weeks versus 32 weeks. I mean, because, the first trimester ultrasound, once you get that crown rump length, is so accurate and so, datable that it just eliminates a huge, just a huge variance that used to be from days back in the past when you were relying on other things like fundal height and, ultrasound at that point, which wasn't that reliable as far as, femur lengths and abdominals, circumferences in the third trimester. So to me, the first trimester ultrasound is kind of the gold standard of OB. It gives you, more information that is so, to me, makes it better to be an OB doc, because I can, everything's based on age in OB, as you know.
Right. And we now have those ACOG guidelines for redating based on ultrasound. And in that early first trimester, less than 9 weeks, if there's more than a 5-day discrepancy between that LMP and the ultrasound, you date by ultrasound.
Exactly. Yes.
And between 9 and basically 14 weeks, 13 and 6, if it's more than 7 days, again, you date based on ultrasound, and that's the due date, and it stays that way, and it's solid.
Exactly. And not only does it do that, but to me, the first trimester ultrasound, you get it that early, the reassurance to the patient, that you have a intrauterine pregnancy, which we kind of go over intrauterine pregnancy like it's nothing, but when you first get a pregnancy test, you got to make sure where it's at. If it's not in the uterus, then that can be a problem. So that's one of the great things to me is, well, where it's at, and once you establish the heartbeat, and just to me, the comfort the patient sees or gets from just knowing that there's a heartbeat and established there, that's worth a lot too. Because back in the old days, you remember trying to do this abdominally, and you couldn't see things, and you remember those days. I mean, and it was just kind of a struggle, and then the ultrasounds weren't that accurate, and I don't know. To me, like I said, I've always said if I could just only have one ultrasound, it would be the first trimester. I mean, I think that's where the money's at, as far as I'm concerned, for most of the decisions in OB.
Right, like you said, it kind of sets the standard, sets the guideline for the rest of the pregnancy, and that's what you go by, and everything else is gauged based on that scan. So let's talk about the AIUM required first trimester images. Can we talk about some of those images and explain what each image, what kind of information that it provides, like seeing the gestational sac, seeing the yolk sac, and seeing the fetal pole, and those kind of things?
Yeah, I mean, once you because we all know that the order of development, and then if you have if you have a gestational sac, or if you have a yolk sac, and then that one picture may not show that much, but to me, if you know that things are developing, over time, then you should be able to develop that, or to establish we have a intrauterine pregnancy that's properly progressing along. Because if you wind up, and you're stuck for 4 or 5 days at the same spot, well, something's wrong.
Right.
So I think that to me, that's what is one of the beauties of this, because now you're doing, we're doing things on the micro level, where used to everything was on the macro level, was like, oh, we're doing ultrasound now and come back in 10 days and let's see. Well, nowadays we, with close follow up, I mean, you can pretty much just see it develop, right as it's developing. And that just offers some reassurance that, we're in the, we have proper growth, we're growing everything. And, there's, but I just think that, if you, because everybody knows the order, and if you wind up out of order, then something's wrong.
Right. And according to those AIUM guidelines, the sonographers should be getting the gestational sac, the yolk sac, the fetal pole, measuring the crown rump length, getting M mode on that cardiac activity, trying to image the ovaries, even if they can't see them, looking at the adnexa, evaluating the uterus for any abnormalities, and determining if there's a multiple gestation. So those are the things that AIUM requires. And in that early first trimester, I mean, that's, like we said, that's the the best time to get all that information.
Yeah, because there's so much information in there. I'm sure you remember, people delivering babies and having a twin and didn't have any idea there was a twin in there, the to me, what I think one of the biggest things in OB that has become more, to me, more comforting to everybody is if you can follow this along and see this on ultrasound, and say you do an ultrasound and you're not sure, and then you repeat it, in a week or so, or 5 or 6 days, just to see the development offers so much more reassurance to the patients than I think that's a big part of it too. I think that just the comfort the patient gets from knowing, hey, things is progressing. We're doing okay here.
Right. And too, now we have, in OB rooms, a lot of times there's a big TV behind the sonographer. We're not turning our screens like we used to. There's a big TV. So the patient can see immediately. So a lot of times, especially if they've had a previous failed pregnancy, as soon as I see the heartbeat, I say, there it is. There it is. Got a baby with a heartbeat. Now let me assess everything else, look at the cervix, the uterus, the yolk sac, and those things. But they're very relieved once we see a baby with a heartbeat.
Yeah, I remember the days, when you weren't supposed to tell them anything, and they'd be in the room and I'd go in and they'd be like, well, her eyes were kind of worrying me. She, but she was telling her anything, she's like, well, I'm not a doctor, but and you're right. I mean, because the patient can kind of pick up on that, and they, to the patient's mind, they just want to make sure everything's okay. They don't, the biology and all that about it, but they just want to be reassured, make sure everything's okay. And I think that if you the ability to do that as quickly as we can do it nowadays, to me, is that's kind of revolutionized OB. I mean, you wind up with so much information, like I said, in that less than 9-week ultrasound, that it's kind of invaluable in obstetrics.
So, and then also we have the ACOG guidelines for diagnosis of pregnancy failure. Mm-hmm. So that helps. We didn't have those before.
Oh yeah.
If you have the standard is diagnosis for pregnancy failure is if you have a crown rump length of 7 millimeters or greater and there's not a heartbeat, there's not going to be one. If you have a sac diameter of 25 millimeters or greater and there's no embryo, there's not going to be one. This is definitive. This is the diagnostic criteria. And if you have an absence of an embryo with a heartbeat 14 days after a scan that showed a gestational sac without a yolk sac, it's not going to go. And then 11 days or more after a scan showed the gestational sac with a yolk sac, if there's no embryo with a heartbeat, it's not going to go. That's the guidelines, and they've been set. And
exactly.
So it's easy now. It's easier now to have those firm lines and to tell the patient, and be upfront, like, I am sure that this pregnancy is not going to go forward.
Yeah, we the ABOG members, we redo membership every year, and this year there's like 60. They call them continuing questions, just about our medical knowledge, and I actually did a few of them last night when I was on call. And one of them was an empty sac that was like 6 centimeters big, and said, this patient presented for early OB care. What is the diagnosis? And I'm like, a failed pregnancy. I mean, that's pretty
early pregnancy law.
Early pregnancy law, exactly. And I was like, so I mean, when things become more concrete and we all agree on them, it just vastly improves what we can do, when we can do it, and how we can do it.
Yeah. So. And so the sonographers have this important role in establishing dates and, evaluating the maternal pelvis and things like that. But now there is screening in the first trimester that's done at MFM to detect abnormalities. But even general OBGYN ultrasonographers can see things like cystic hygromas and, maybe a persistent omphalocele that's not, physiological. They can see abnormalities in the brain, even heart abnormalities and things. So even general OBGYN sonographers need to pay close attention to those signs in the first trimester that there might be abnormalities or structural abnormalities.
Yeah, especially, even, today, they have the early, cell-free testing that we do. And that kind of opens up a whole nother days of discussions. But anyway, but you think about about when we used to just do the. Remember, we did the nuchal translucencies, which you were one of the first people to ever do that. I mean, because the earlier you can detect an abnormality, and you're sure of that abnormality, then you have a lot more options. And I think that, to me, when you start talking about abnormalities and you start talking about, decisions that couples face, you need to be 100% sure before you reach out there and say, I think this is what we need to do. And I think that's what these early ultrasounds are doing for us, especially with today's machines. I mean, being able to see, what we can see, so clearly. I just think that's really changed OB in the last 30 years.
Oh yeah. I mean, we can measure yolk sac size now. We can see the yolk sac well enough to measure it.
Yeah.
If it's greater than 6 millimeters, all the red flags go up.
Yeah.
It could be, a sign of a failing pregnancy. So when should a patient be referred to MFM in the first trimester for further evaluation? Like, what are some of the scenarios that you might refer a patient?
I mean, we don't, our MFM is a little distance away. So we generally, we may do phone conversations. We really don't refer a lot in the first trimester anymore. Or yet, I'm sure that's coming. But in the rural setting with our ultrasound techs, the way we kind of do it is we may follow along and get multiple pictures, and then I may just consult the MFM. But like you said, if you have the persistent cystic hygromas, or if you see any what is not normal, that but I think that we don't use early MFM referrals a lot yet, just because we're kind of rural, but we're getting to that point where that just that conversation is important. We can say, hey, this is what we see, and actually send an image, and then they say, this is what you need to do back. But I think that that as we get bigger in the as MFM becomes available, especially now with the telemedicines, and the computer links and everywhere, which, as you know, I'm not a computer person. I think that getting their input into it so much earlier again offers that a greater level of confidence when you do suggest things or offer things.
Yeah. And then with that NIPT starting at 9 weeks, if that comes back abnormal, do you refer to MFM then for the first trimester screening?
We usually, the way we're doing it now is usually we have to send them. It's about an hour away to MFM from where we're at most days, and we're kind of usually waiting to around 12 or 13. But a lot of our patients, really, they kind of show up. We don't have a lot of real early pregnancies. Most of them show up, because we work in a very rural place, and by the time they get their paperwork and their insurance is adjusted, we're usually about 8 or 9 weeks that we're getting that first really good ultrasound and visit with them. And and in smaller places, people may not realize sometimes there's a wait to get in to see the OB doctor. I mean, they
right.
But and that's one thing that my clinic is doing is we're starting to use mid-levels a whole lot more to just get them in the door and get that ultrasound, because the doctor don't have to be there for the ultrasound. If we get that ultrasound and something's not right, then we start that progress, or that process. But our MFMs, I remember back in the old days, and you may remember this, MFM wouldn't see them unless they was past 14 weeks,
right.
It wouldn't, don't send me anybody, and now
they're seeing them for an 11 to 14 week first trimester screening.
Yeah,
they're looking at the brain, the heart, and trying to detect any abnormalities that early.
I had yesterday in clinic, I had a patient who had just seen MFM, and she was 11 weeks, and I mean, she was seeing them for medical problems, her own medical problems. And I was, I was thinking, 20 years ago, MFM would have never laid eyes on this lady because she wasn't 14 weeks,
Right.
So I think that the earlier you can get them in, and what I'm seeing in the rural places is just the ability to send them a picture or to send them a question and be able to get that question answered in the same day, to me is just revolutionized what we do.
Right. Right. To have that instant
Yeah.
feedback is
Yeah.
important.
And not only, because, a lot of our people may drive, hour and a half to come to the doctor, and we can get a lot of things accomplished in one visit nowadays, where it used to be, 2 or 3 visits.
Mm-hmm.
You remember by the time we used to get them from Southern Illinois to St. Louis and then back, you'd be spent 2 or 3 weeks sometimes trying to get that route. Now we're getting it done, within 24 to 48 hours. And that's, to me, is really kind of revolutionized things.
Right. And so much has changed. Like you said, improved image resolution, advances in transvaginal imaging, earlier diagnosis. What about the future role of artificial intelligence? What about AI? What do you know about that?
And I have a nephew. I had to throw in a plug here, who has a PhD in artificial intelligence. And his exact words were, he said, what they're trying to do with artificial intelligence, if you knew, you'd have difficulty sometimes sleeping at night too. And I'm like, to me, AI is going to kind of revolution. We were joking about that this morning at work, that soon you're going to be able to go to Walmart, sit in a box, tell them your complaints. They're going to take your blood pressure and temperature and a few things, and you're going to be able to walk out of that box with a script in your hand and telling you what's wrong with you. It's going to be very Star Trek-ish, and I don't know. I mean, that's a whole nother can of worms, as they used to say. But I do think that AI is really helping us as far as, from what I hear in radiology, helping them to read films and all and miss, things that, but I don't know, that's going to be an interesting thing as it progresses.
Yeah.
It's going to take away, I don't know, you know me, I'm old, and the relationship that I develop with my patients and the camaraderie, to me, that's part of being an OB doc, because by the time you spent your gestation with me and we show up for delivery, you should feel comfortable with me. You should, know what I'm thinking. I should be able to have a discussion with you, and kind of develop that friendship. And I'm just afraid that model may be gone, but there again, that's just me being old again. I like the way, I like that, but I do think that AI is going to be a very interesting things that they're going to be able to do with AI and computers and, just images. And, it's fascinating to see it, but, I'm kind of glad I'm not the one developing it, because, sometimes I wonder about, you remember the Pandora box, you may be opening something you may not want to know down the road, so.
Right. And I think, government is working on regulations and things like that, trying to desperately keep up with it. But so, I mean, I feel like you have to embrace it a little bit, because it's here, it's only going to, be affecting every industry even more than it is now. And it's happening so fast. And there are some good things, I think. There's a lot of, assistance on ultrasound machines now. And, there's a lot of good, but I get it. There needs to be some regulation. And I agree that face-to-face with your provider and that human contact, you can't replace that.
You talk about, just, like we already alluded to, the advances just in OB ultrasound quality images, I mean, as things progress, we expect, we expect progression of everything. Nothing stays the same. So, the question is, like you said, if there's some guidance and, and I think that AI and computers and all that, I mean, well, go back to the COVID days. Remember when everything was done by telemedicine? I mean, 50 years ago, that would have been possible to do. So I think technology is really helping medicine. I worry about where is it going, and what are the decisions it's going to be able to make without some kind of, guidance and, all that. But I mean, I think that, that I think you're right. I think as long as there's, overview and, we kind of keep our eye on it and rein it in, it's going to be a great thing. I mean, you think about how much better our life is nowadays than it was, 50 years ago. I mean, me and you talking on this little handheld device 50 years ago would have been a joke. Oh, you couldn't do that.
Right. We remember when there were no cell phones, and then when the cell phone came in a bag.
Yeah. I was 14 years old before we ever got a phone in the house, and it was on the wall, and you shared it with 3 other households. They remember the old party lines.
Oh yeah. So if there was one key message you would like for sonographers to take away from today's discussion about like first trimester scans and the impact that it has on the patient, what would you like? What would you want it to be? What takeaway?
I think that to me, when you're getting that first trimester ultrasound, just to realize that what that does. I mean, that establishes, the due date, viability, is there an abnormality early? I mean, to know that that's a lot of information, that we as OB providers, I remember, when you got your first ultrasound at 16, 17, 18 weeks. Remember that, and,
Yeah.
And to just know that how much information that really relays to us, and about how much that we depend on that to make decisions, and, we make, there may be an important decision, because there's a big difference between, delivering a 36-week baby versus a 32-week baby, I mean, so to me, that information that the ultrasonographer provides at this point, this early is very important. I mean, and it can make a big difference in the cure of that patient as the gestation progresses.
You're exactly right. The big key takeaway is what sonographers do, what they say in the preliminary report, the measurements they take, always impacts clinical decision making and delivery timing. So, Dr. Sanford, thank you for joining us and for sharing your expertise on such an important topic. And thank you to our listeners for tuning in to the Seasoned Sonographer podcast. A special thank you to our sponsors, Sono, Southern Illinois Healthcare, Rochal Health, and Sono Techniques Academy for supporting ultrasound education and excellence in patient care. I'm Lynn Flam. Until next time, keep learning, keep scanning, and keep making a difference in the lives of your patients. Thank you so much for joining me for this episode of The Seasoned Sonographer. If you're interested in improving your OBGYN ultrasound skills and learning more about the field, make sure to subscribe to The Seasoned Sonographer on Apple Podcasts, Spotify, and YouTube. You don't want to miss any of the upcoming episodes. You can also connect with me on Facebook and Instagram at Sono Techniques Academy. Explore more educational resources on the Sono Techniques Academy app, or reach out via email, lynn@sonotechniquesacademy.com. I'd love to hear from you. If you have questions or topics you'd like for me to cover, feel free to reach out. This podcast is for you, and I want to make sure I'm covering the topics that matter most to you and to the ultrasound community. Until next time, keep striving for excellence in your scans, and I'll see you in the next episode of The Seasoned Sonographer. The information provided in this podcast and any accompanying materials is for educational and informational purposes only. It is not intended as a substitute for professional medical advice.